Hello again, everybody. Welcome to case study number 46. I think I'm pregnant. If you haven't had the chance yet, please consider subscribing to my Patreon. You can get there by clicking the link in the description of the video or on the I button in the upper right-hand corner. I very much appreciate all the contributions that I can get to help offset the cost of these videos, and I thank all those of you who have already stepped up to donate. And if you want, for completely free, you can subscribe to my channel. I try to put up videos every day or every other day, and I've got a lot coming out right now, so definitely subscribe and you'll get notified when I put more videos up. Okay, so we got a 21-year-old nulla gravida who presents to the clinic because she has missed her last 2 periods. She normally has regular periods about every 27 to 29 days, and she says that over the last few weeks, she's also had nausea and some vomiting, which she originally thought was the flu. She endorses fatigue despite sleeping 8 hours every night, and she endorses breast tenderness. She's a college student and has no significant past medical history, including no STDs. She is sexually active and did have sex about 3 weeks after her last period. She says that her boyfriend pulled out, so she didn't think she could possibly become pregnant. Oh boy. She's on no medications and her vitals are within normal limits. So what do we think is going on here? All right, so this is a young woman who is not having safe sex, contrary to her belief. And she's got nausea, and she's got vomiting, and she's got breast tenderness. And I bet you if you ask her when her nausea and vomiting is the worst, she's going to say in the morning. All right, so her physical exam is pretty much normal. She's got some mild breast tenderness, normal external genitalia. Very important to do your genital exam, by the way, when you've got a pregnant patient or a possibly pregnant patient. Vaginal mucosa is normal. She's got a closed cervix. The uterus is enlarged on bimanual exam. Everything else is normal, though. So what's her differential? It's not very big. She's probably pregnant. So this could be just a regular old normal pregnancy right now, or it could be a pregnancy complicated with hyperemesis gravidarum. She is puking a lot. So throwing up does not mean that you have hyperemesis gravidarum. There is regular old nausea of pregnancy, nausea, vomiting of pregnancy, morning sickness. That is not abnormal. Hyperemesis gravidarum is abnormal. So how do we tell the difference between the two? We'll get to that. Then there is the possibility of anemia. She's tired. We didn't see any pallor, but you got a person, especially a woman who's tired, you got to check for anemia. So what are we going to do for our workup? Well, you got to get a qualitative beta-HCG. That can be done by urine. You wouldn't be wrong if you got a quantitative beta-HCG via serum, but we're just checking a yes or no question here. Is she pregnant or is she not? Quantitative beta-HCG is more for determining whether her pregnancy is progressing properly or, if we're thinking the possibility of a molar pregnancy, then you would want to get quantitative. But qualitative is what you would get if you just want to know yes or no. We're going to get a urinalysis, and then we're going to get a CBC because of the possibility of anemia. And what do we find? A positive qualitative HCG, so she is certainly pregnant. Urinalysis shows trace ketones, but no proteinuria. So what that's telling you, the trace ketones, is that she's probably a little bit malnourished, and that's likely due to all the throwing up. And usually when you're nauseous, you're not eating very well. Ketones, trace ketones, just means you're a little bit on the, mildly starved side. If you go a day without eating, or you go even, 18 hours without eating, you'll probably have a little bit of ketones in your urine as well. Very easy trick to do with patients. If you see ketonuria, just walk in, as long as they're not diabetic, walk in and say, you haven't been eating in a while. You need to eat something. And they'll be like, oh, how did you know that? CBC is within normal limits, so no anemia. Our diagnosis here is pregnancy. So when you make a diagnosis of pregnancy, your next step is to do an ultrasound. So we're going to get a transvaginal ultrasound, and on CCS that will likely be listed as fetal, but make sure that you're doing a transvaginal ultrasound because in the first trimester of pregnancy, we do transvaginal ultrasounds. So you got a woman who's 300 pounds, abdominal ultrasound in the first trimester is not going to be very good. So we do the transvaginal ultrasound. It's always going to be great for the first trimester. Once you get second, third trimester, then you can certainly do a transabdominal ultrasound. We also want to obtain her baseline weight and compare it to her previous weight. That's going to be important to determine whether or not she's got hyperemesis gravidarum. This is what we see on the transvaginal ultrasound. It's an intrauterine singleton pregnancy. She is most certainly pregnant. What we really want to do, though, and I apologize, I can't circle this in red here, is we want to check that crown rump length. That helps us date the pregnancy. And because this is her first ultrasound, it is helpful to have a date for the pregnancy. And what we find with the ultrasound is that she's got an intrauterine single pregnancy with a crown rump length of 3.3 centimeters. That's consistent with 9 weeks gestation, and we see cardiac motion. The baseline weight shows no weight loss compared to her weight 8 months ago, so that is reassuring. Please note that early ultrasounds are more accurate than late ultrasounds. So if you get an estimated gestation on your early ultrasound and then you get an ultrasound 10 weeks later and you get a different date, don't change it. The final diagnosis here is an intrauterine pregnancy. Now, this is the management. So you can see that if you get a question like this on CCS, it's going to be fairly easy to determine she's pregnant. The hard part is remembering all the things that you need to do at the initial pregnancy visit. So we get a CBC. We want to check her blood type. That's going to be really important going forward. And then, of course, we're going to get a urinalysis, and then we check all of these things that may impact her pregnancy. So first of all, we need to make sure that she's immune to rubella and varicella. We also need to check for all of these STDs. So we're doing the whole shebang here. We're getting a hepatitis B surface antigen to check for active hepatitis B. We're going to get a VDRL. We're going to get an HIV antigen antibody. And we're going to check for gonorrhea and chlamydia. And we'll offer a pap smear. You should include that on your orders, but not all women will want this. They don't have to do it if they don't want to. General pregnancy counseling needs to be on a prenatal vitamin, especially now. We'll counsel just general prenatal counseling. Make sure you're wearing a seatbelt, no alcohol, no drugs, no smoking. Because this is a patient who's having a miserable time right now, she's throwing up, we can offer an antiemetic. We don't need to go for your traditional antiemetics like metoclopramide and stuff like that. You could just give regular old antihistamines. The common one to give is doxylamine pyridoxine combination, also known as diclectin. You will need to order both of these separately on CCS, however. I checked the CCS database. It does not have diclectin, so make sure and give pyridoxine along with doxylamine. This is the typical treatment for nausea in pregnancy. We don't go for Zofran or Reglan or anything like that. And then we're going to follow her up in 2 to 4 weeks for her first trimester labs. We typically do that at 11 to 14 weeks. And what we're getting here is the PAPA, which is a lab. We're getting an HCG, and we are getting an ultrasound for nuchal translucency. So those will all be done at 11 to 14 weeks. She's not quite there yet, so we'll check her up in 2 to 4 weeks for her first trimester visit. Common differentials, hyperemesis gravidarum. She may have had that, but in order to have hyperemesis gravidarum, you need to lose at least 5% of your pre-pregnancy weight. And then anemia, obviously, if it was just anemia, she would have a low hemoglobin, not pregnant. Certainly, you can have anemia while you're pregnant, but she didn't. She had a normal hemoglobin. All right, recapping, all women of childbearing age with secondary amenorrhea, that means that your period has stopped, but you've had them before, should be screened for pregnancy, and that means a qualitative urine beta HCG. Once you've confirmed it, the next step is to estimate gestational age with a transvaginal ultrasound, and that is superior in the first trimester or in very, very, very obese patients. I don't know if you've seen the 1,000-pound sisters, but one of them got pregnant and, morbidly obese. Probably best to go with a transvaginal ultrasound no matter what in a patient like that. But definitely first trimester, everyone gets transvaginal ultrasounds. Prenatal visit, So we will see them every 4 weeks in the first and second trimester, so up to 28 weeks. Then after that, she's going to be seen every 2 weeks, up to 36 weeks. And then at 36 weeks, we will see her once a week up to delivery. So you should remember that. Will be useful for you in the clinic and if you're doing an OB rotation.